I want to thank you for this opportunity and say hello to my many friends around the world. I'm speaking to you from New York City. I have no financial interest to declare. I will be discussing the off-label use of chemotherapy in children. There's no chemotherapy in the United States approved for children. By way of background, our retinoblastoma program in New York City at Memorial Sloan Kettering is the world's oldest. We have been seeing patients for 107 years, managed by 3 physicians, Algernon Reese, Bob Ellsworth, and me. It's generated more than 500 publications and books over the year, perhaps best known for the Reese-Ellsworth classification, for Reese and then Ellsworth's work on radiation, for our introduction of the use of pre-implantation genetic diagnosis in retinoblastoma, our work with Lorenz Zimmerman, Fred Lee, and Joe Framweni on second cancers, and what I'm going to talk about today, our experience with intra-arterial chemotherapy, which we introduced in May of 2006. Since moving to Memorial in 2004, we have passed doing 20,000 examinations under anesthesia. And really, the story of intra-arterial chemotherapy can be told by contrasting 2 articles I wrote. One in 2003, when I summarized our experience to that point, saying that patient survival was 86% and ocular survival was 4%. We were enucleating virtually all unilateral eyes and many bilateral eyes. And when I wrote a similar article in 2019, patient survival was now up to 99%, and ocular survival had gone from 4% to 95%. We don't enucleate very often. And amazingly, 90% of our patients have 20/20 vision in at least one eye. How did we do this? We did this by treating very advanced disease. These are 8 eyes that were all treated more than 10 years ago. Patients are alive and well. The history of intra-arterial chemotherapy is known to all of you. It was really first done by Reese in the 1950s with TEM by direct injection into the carotid artery. We now realize that very little of that got into the ophthalmic artery, and really he was doing pioneering work on the use of intravenous chemotherapy. And it was the Japanese working in Japan who have collected more than 30 years of information. They introduced the small catheters with a balloon, and they introduced the use of melphalan for retinoblastoma. They had very good results. But those very same patients had external beam radiation with hyperthermia, had intravitreal melphalan and intra-arterial chemotherapy, so it was difficult to know how much of the success was related to intra-arterial chemotherapy. What I'm going to talk about now is the technique I introduced with my colleagues in 2006 using melphalan, carboplatin, and topotecan. And here's our very first case of a child who had scheduled for enucleation. We treated, we waited 3 weeks, and when the child came back, it was obvious that the world of retinoblastoma was about to change chemotherapy. Ophthalmic artery chemosurgery, as I prefer to call it, is an outpatient interventional procedure. The actual treatment takes an hour, although the children are there for 4 or 5 hours. It's repeated an average of 3 times, although as few as 1. They have a CBC 10 days later. They don't require ports. They don't require Bactrim prophylaxis. The drugs we use are melphalan, carboplatin, and topotecan. And at the end of this, the total amount of melphalan they've had is under a half a teaspoon. Now remember, melphalan comes in 2 forms: Alkeran, which is more expensive, less stable, and has to be filtered because it has propylene glycol, or Evomela, which doesn't have to be filtered, has a longer half-life, but is more expensive. We use Evomela exclusively. What about our results? I mentioned that our patient survival is over 99%. It's not 100%, but it's over 99%. We've done more than 2,400 infusions. 3/4 of them are in unilateral patients and 1/4 in bilateral patients. Second cancers are not increased by doing this. The only second cancers we've had so far are the pineals in bilateral patients, and they're at the incidence that we would expect to have. How about success? For primary treatment of both group D and E eyes, we've saved 95% of the eyes. That's true for unilateral or bilateral, and most amazingly, for patients who have failed systemic chemotherapy unilaterally or bilaterally, we save 95% of the eyes. And finally, for patients who recur after intra-arterial chemotherapy, which happens in 10 to 15% of the cases, doing it again saves almost all of the eyes. We've had no procedure deaths, we've had no strokes, we've had no vascular occlusion of the leg, we've had fever of neutropenia less often than 1% of the time. We haven't transfused a patient in more than 10 years. We do have a 1.5% incidence of loss of vision, and I encourage you to look at this paper because we think these choroidal infarcts may be related to the use of nitrous oxide in patients who are homozygote or heterozygote for the MTHFR gene. 15% of the time we got this rash-like appearance which blanched in the distribution of the supratrochlear artery. Now remember that the largest branch of the ophthalmic artery goes to the supratrochlear artery, not to the eye. And we eliminated that by placing neosynephrine at the beginning of the procedure on the forehead and in the nose to blanch and occlude these vessels temporarily that shunts the blood into the eye. It's an important technique. I'm going to show you a series of eyes now that all have driving vision. And not only should you note the dramatic response of the tumor, but look at how healthy the retina looks. The pictures speak for themselves. Here's an only eye, the other eye is out. And would you have predicted that this next eye might have vision, total retinal detachment, can't even see the optic nerve? One treatment, and this patient long-term has 20/60 vision, which is good enough to get a license in New York State. And would you predict that this patient with a detachment just above the fovea would have good vision? Long-term, 20/25. Amazingly, a quarter of patients who have extinguished ERGs land up with improvement in retinal function as the retina settles down. Now, the more you do this, the better you get. We show that between 2005, 2010, and 2014, over these 5-year periods, our success rate in our own hands using the same drugs has improved. It's cheaper than intravenous chemotherapy. Remember, most of the cost of pediatric cancer care is in managing the side effects of cancer treatment, the ports, port infections, antibiotics, hospitalizations. Studies now published from our center, Argentina, Chile, and Switzerland show that intra-arterial chemotherapy is actually cheaper overall. You know the systemic chemotherapy affects immune function, but intra-arterial does not, and we've published on that. So these children can be immunized. For patients who have total detachments, a little over half of them completely reattach, usually within a year and a half, and 3/4 of them have partial improvement. And that's why the ERG improves, of course. What about patient growth? You know that patient growth is affected with systemic chemotherapy. Intra-arterial chemotherapy, as we've published, does not affect growth. Here is that first patient in the world who had intra-arterial chemotherapy, and at the age of 14, she's almost as tall as I am. Those of you who treat retinoblastoma know that it is common in the genetic form to develop new peripheral tumors in the eye. In our experience, it's 53% of the time. With intra-arterial chemotherapy, it's only 4%. It is very unusual to see a new tumor develop in an eye that has intra-arterial chemotherapy. We say that it prevents new tumors, but I don't think it prevents new tumors. Based on our paper published in Nature in 2015, we believe that all retinoblastomas are actually present and develop between the age of 26 and 28 weeks in utero, but may not appear for months or even years. So what we're doing is treating tiny tumors that we don't appreciate ophthalmoscopically. In summary, the impact on my practice at Memorial Sloan Kettering has been that we abandoned radiation 15 years ago. We have not used systemic chemotherapy for intraocular disease for 13 years, except in the children in the first 3 months of life. We've decreased the nucleation from 95 to 5%. A third of eyes with extinguished ERGs regain some function. It is cheaper, and we've done this without compromising patient survival. Thank you.